Dr. Mudit TYAGI, please.
Can I please have my slides here? All right, so good afternoon, and first of all, let me thank the scientific committee and Dr. Malika Goyal for having me as a part of this session. So I'll be talking about managing peripheral membranes in hypotony. But before we go to managing membranes and hypotony, we do need to understand what exactly do we mean by hypotony and how does it affect us, what are the different types, and what's the reason why that hypotony occurs, so that then we can understand how removing membranes helps in taking care of the pathogenesis and the problems that happen. So hypotony essentially is low pressure which may be transient, chronic or permanent, and which leads to functional and structural changes. Can be acute as well as chronic. Acute is seen usually immediately early post-operative and usually can be related to surgeon-related surgical factors, is often reversible. If it resolves within 15 days to 1 month, it's termed as transient, and it usually does not cause any irreversible functional loss. Now, when do we label a hypotony as chronic? You do not have any absolutely well-defined definition, but an IOP of less than 5 for more than 3 to 4 weeks is what we label as a chronic hypotony. And how common is that? In the silicone oil study, they found that around 24% of eyes had a chronic hypotony, and another study, the vitreous study, showed around 18%. So chronic hypotony does tend to occur, and we need to understand why this occurs. Now, what is the reason or what's the pathogenesis behind a postoperative hypotony? It can be an increased outflow, in which case, like there's an improper port closure, or a scleral perforation, or a necrosis that can happen sometimes post-inflammation. So you need to take care of that. There can be internal fistulization. There can be an outflow into the suprachoroidal space through a cyclodialysis cleft. And this is now what we need to remember. So remember this point: development of a cyclodialysis cleft. That is the other thing that can happen. Apart from that, there can be retinal detachment. So peripheral retinal detachments. So you may have a retina which is attached to the posterior pole, but you may have a detachment beyond that. So you may have put a belt buckle, and what you may see is that the posterior pole, the retina is well attached, but the peripheral retina beyond the buckle or beyond your laser marks may be detached. Now that is a cause of concern, because not only will that lead to a postoperative hypotony, it can also in future predispose or lead to neovascular glaucoma, peripheral neovascularization, and an NVI developing over there. So if you see an eye post-detachment developing an NVI, please suspect a peripheral residual detachment in the extreme periphery, which is the one which is leading to all of this. Inflammation again is one more cause. So this was one patient in which there was this large area of bare RP, and that in itself can lead to it. So bare inferior RP in eyes where we do an extensive retinotomy in itself can lead to inflammation as well as a subsequent hypotony. So that is another reason why some of these eyes do develop hypotony. And this was, like I was said, this was a case which was referred to us, and when we saw, you can see these laser marks, and the retina, while it's attached to the posterior pole, the entire retina in the periphery is lifted up, and that again can lead to subsequent hypotony. Apart from that, there will be a damage to ciliary body and a chronic traction at the anterior vitreous base, again reasons for leading to hypotony. Now, where do peripheral membranes come in this entire picture? Peripheral membranes essentially lead to all of the points that we have discussed till now. They lead to an increased incidence of peripheral retinal detachments and recurrences. They can cause a traction and lead to ciliary body detachments. They can cause an inflammation, and they can in the long run lead to a ciliary body shutdown, which can also happen because of the combination of all of the other factors that we have discussed till now. So let me show you one case and how removal of these membranes can help. So this was a patient who had undergone a retinal surgery elsewhere, was referred to us. This patient had also undergone a silicone oil removal in November last year. But post silicone oil removal, while the retina is attached, the patient is maintaining an IOP of just 3 millimeter. The visual acuity is 20 by 600, and if you look at the OCT, you can see these entire areas and these extensive retinal folds over here. So this is a patient who is having a persistent hypotonic maculopathy which is happening, and this is an eye which is not likely to recover unless and until we take care of the hypotony that is happening over here. We did at UBM. Now UBM becomes an extremely important tool in a lot of these eyes, which helps us see this extensive peripheral CDs over here and this detachment that has occurred in this eye. So let me show you what we did. So this is a patient. So we went inside, started removing a lot of this peripheral membrane, and now if you look over it, you will see that there are these thin sheets of small peripheral membranes and these bands over here. You need to take care of these membranes. So Dr. MPS sir had shown a video where you could indent, and by indentation reach all the way up to the pars plana and remove these membranes. So see these membranes. And now you start indenting and you start seeing all of these peripheral membranes. So a lot of times you can indent, but a very valuable tool in these eyes can be endoscopy. So now we have started utilizing a lot of endoscopy, which allows us a visualization. So in this case, I was able to visualize, and then with the help of an endoscopy assisted visualization, you can take a scissor inside or a forceps and try to cut and remove all of these membranes. So even if you can't extensively remove all of this, even if you truncate it, you are relieving the traction. So truncation of all of these peripheral membrane bands, or if you can possibly peel them all off, then that helps. In the areas where there was a detachment and cyclodialysis, what we also did was we did a cryo. How does cryo help in some of these cases? Cryo leads to inflammation, and that subsequent inflammation also sometimes helps in closing some of the cyclodialysis clefts. If that doesn't happen, then sometimes you may have to go for a cyclodialysis repair also subsequently. This was another case. These are videos which I took from Dr. Rajiv. Again, in these cases, again, we did an endoscopic visualization, tried to remove all of the peripheral vitreous which was left behind, and then subsequently with the help of a cutter or even with the help of a scissor, you go around truncating or cutting a lot of these extensive peripheral membranes. So removal of these peripheral membranes becomes important. Subsequent to removal of the peripheral membranes, in the previous case, what we did was we have again injected 5000 centi-stroke oil, because we need to keep that in so as to ensure that the hypotony goes away. The patient on the first post-operative day is maintaining an IOP of 11. 1 week later also was maintaining an IOP of 14. We are still awaiting a long-term follow-up to see how the eye evolves. But the vision right now is 2400. Not much of an improvement from 2600 to 2400, but too early. But essentially the IOP has started building up now in that eye. So in a nutshell, post-operative hypotony is a challenging condition. You need to have an individualized approach. You need to see what is the reason for the peripheral hypotony to occur. If it's a peripheral detachment, you need to take care of that. Removal of peripheral membranes becomes important, because unless and until you remove those peripheral membranes, the underlying cause of that hypotony is going to persist. Thank you so much.
It's very good. So basically, UBM and endoscopic surgery are key to managing this case.
Yeah.
Dr.
The
Mohit
essential
Dogra will
thing
make
is a visualization of the periphery. If you can
Yeah.
indent and then see, then also it's important. Till we had endoscopy, the only way we were doing was we were trying to indent, and remove as much of peripheral membranes as possible. Because now we have endoscopy, it's made life slightly more easier.
Yeah, that's right. Dr. Mohit?
Great talk, Mudit. Just had to add 2 points regarding cyclic membrane removal. So peripheral membranes, absolutely, as you said. But I think once you get down to cyclic membranes, pre-op UBM is a must. And 2 things. If the media is clear, in my mind, because I do, unfortunately, more than my fair share of these in these young pediatric uveitic eyes, deep anterior self-scleral depression gives you spectacular view. Much better than what you can ever get, even in superb hands like Dr. Rajiv, better than that. If the media is not great, separate story. But I think we must trifurcate the presence of cyclic membranes based on 3 different etiologies. So uveitic eyes can chronically get cyclic membranes. Post-penetrating injury eyes can get, neglected cases can get, and multiple VR surgeries ones can get. Yeah. So typically your post-uveitic eyes will not be as vascular as they will be fibrotic. So actually removing them is more challenging, but bleeds less. So it's more like a TRD, which is not as vascular. The ones that form post-endophthalmitis or post-multiple VR surgeries are very vascular. So removing them becomes, is a big issue. They bleed a lot, and there actually trying to get them off becomes extremely, extremely difficult. There you actually need to just try and truncate, and if you can get one quadrant free, you're good. Because, if you were to look at your glaucoma people, when they do DLCPs, they will try and ablate 3 quadrants, leave 1 quadrant, and that is good enough, that amount of viable ciliary body for the eye to do what it does. So if we can get 1 quadrant free, maybe try and look at 2 quadrants and get a few of those ciliary processes free, I think we are able to get the eye out of that vicious cycle of hypotony and breathing again, so to say.
Yeah, so that is also in eyes where you're not able to peel the entire membrane, a good thing is to just go truncate. Cut in 2 or 3 areas. That essentially relieves the circumferential traction that is causing all of those subsequent points.
Mudit. So great talk. So any role for methotrexate in these eyes?
So methotrexate works usually in preventing PVR. These are membranes which have already occurred. So like what we had discussed earlier, the essential thing in these eyes is to remove the membrane, because the membrane is the one which is causing all of the subsequent problems. Methotrexate will essentially reduce probably the incidence of PVR that is there. But the essential etiology behind why all of this is happening is because of the membranes. So you need to take care of those first. Yeah. To
Thanks.
be honest, I have not tried methotrexate in these eyes.